So hello everybody, this is Ken Accardi. I'm going to be presenting your webinar to you today. So thank you so much for joining us. And today we're going to talk about affordable home care offerings to reduce readmissions. And this is actually part of a 3-webinar series where in the last webinar we talked about how payment models are changing, and it's really changing the way that hospitals in particular are thinking about post-acute care. So we'll review that for anybody who missed that webinar. And then really today is going to be more of a webinar about entrepreneurship. It's about there's an opportunity, and we want to talk about how you and your agency can seize that opportunity. So that's what we're going to be covering today. A couple housekeeping things here is that everybody on the webinar, you're in listen-only mode. So if you speak, we won't be able to hear you. But if you have a question that you'd like to have us address at the end of the webinar, we'd be happy to take those at any time. So anytime you have a question, just type it into the question panel on your GoToWebinar console. And if there's something logistically like you can't hear or anything like that, just let us know via the question panel as well. We'll have somebody monitoring that, and they will intervene if there's something that needs to be done. So just a quick bio about myself. I run a couple software companies. One's called Ancoda. We make software mostly for non-medical home care and managing care transitions. And another company called Triple Aim Technologies that has a remote monitoring capability that is very affordable and scalable for checking in on people in their homes and trying to prevent rehospitalizations and readmissions. So that's what I do, and so with that we'll kind of jump into today's webinar, and we'll start with learning objectives. So really, as I stated before, we're going to review the changing payment models that we covered in the previous webinar, and then we'll talk about many people have heard about the readmission penalty program that went into place starting in 2013, and candidly it wasn't as maybe effective as people hoped it would be, because, you know, I'll just summarize that right now. Hospitals are penalized if their amount of readmissions exceeds certain benchmarks and that kind of thing. But even though the penalty rose and rose over the 3-year period, really it's not a very consequential penalty for the hospital. In a worst case scenario, it's around $250 for the hospital, and if somebody readmits, they're charging multiple thousands of dollars for that readmission, and a lot of the hospitals have just said, okay, I'll pay the penalty, but I'm actually making money on the readmission. But we're going to talk about why that's changing now, and I'll cover this in upcoming slides. Basically, CMS, who's the biggest payer, you know, the Committee for Medicare and Medicaid Services, is really pushing the payment model in a very different way to what they call value-based payments or value-based purchasing, and there's programs like bundles and accountable care organizations where it actually becomes the financial responsibility of the hospital, or, well, I guess in most cases the hospital, to pay for that care, and that's really opening up a very different way of thinking on their part. So sorry for expanding on that so much here, but I think it's just important to cover. And then we'll really kind of jump into the entrepreneurship part of the session. We'll talk about different offerings that you can craft that would be attractive to hospitals. And finally, we'll talk more strategically about really where post-acute care is going and how you might position your agency for the future to win. And by the way, we do have one more webinar coming up, and that's really going to be the main focus of that final webinar is really what does the successful home care agency of the future look like, and how do they work. So just a little bit of a recap for those of you who did attend the previous webinar. You saw this slide before, and this is actually from a guy named Josh Luke, who's in California, and he talks about readmissions and bundled payments a lot, and I borrowed this slide from him that really captures what people are thinking on post-acute care. So if you kind of start at the top, the last place you want to have people is in the hospitals, where readmission is very costly, and again, as I mentioned, it's an out-of-pocket cost. So we really are getting to the point where avoiding a rehospitalization is really, really critical, and that's the last place we want to be. But kind of moving down, we talked in the last webinar about how generally the hospital would just say, well, yeah, this person really can't take care of themselves, I'll send them to skilled nursing, or this person can kind of take care of themselves, I'll send them to home health. And so now with this new way of paying where the hospital is paying out of their own pocket, the skilled nursing facilities look very unattractive, and I'll show you that with some financials that I just got some information. There was a nice article in the Wall Street Journal on Friday with a graphic that I've added in. I don't think it's in your handout, so if you want that slide you could just look it up on Wall Street Journal, but it basically shows how the costs break down. And what's really going to happen is that the hospitals are really going to be saying, hey, if this person really can't take care of themselves, do I really have to send them to skilled nursing, or maybe they could have home care to take care of them? So that's going to be the new thinking there. And then you move down to home health. Home health is an attractive option and will continue to be. And I'll show you again in the Wall Street Journal slide that a discharge to home health should be profitable for the hospital, which is great. However, there are other initiatives, one that we talked about at length in the last webinar, specifically the home health value-based payment or value-based purchasing program, where there's a deliberate effort to, cut down the ranks of home health agencies and really reward those that are performing better and actually discourage those that aren't performing very well from even staying in the business. And if that's something you missed and you want to know more about, just ask us and we'll get some information to you about that. And so finally, if we jump into who wins in this equation, it's really opening the door for home care, private duty, and assisted living, because if the hospital can get somebody into one of these settings and they're maybe paying on their own for home care, then that's very, very attractive to the hospital in this new paradigm. So here, just kind of recapping some of the things from the previous webinar. 30% of the discharges in this year will not be paid by Medicare, and that number is growing. They'll be instead paid by things like bundled payments and accountable care organizations. And actually, the bundled payment for joint replacements has gone into effect in a number of states actually as of April 1st, so that's why the Wall Street Journal covered that article. So let me talk a little bit about what those are. So I'll start with ACOs. It stands for Accountable Care Organizations. And what this is that part of the Affordable Care Act looked at how we might transform care in the future, and they looked at some successful models that you may have heard of, organizations like Kaiser and the Mayo Clinic and the Geisinger system in Pennsylvania. And what made these organizations unique is that they actually combined the payer and the provider of care in one organization so they could manage the risk. And by doing that, they, in these organizations, have actually optimized care and try to cut out duplication of services and worked in teams as doctors and other care providers to provide better care at lower cost. There's a great article in the New Yorker by a guy named Atul Gawande, who's a doctor here in Boston, and he actually compared and contrasted people living in Rochester, Minnesota, where the Mayo Clinic is, to people in McAllen, Texas, where something like that wasn't in place. And it turned out that in McAllen, Texas, the cost per Medicare beneficiary was much, much higher, and the health outcomes were much, much lower, whereas in Rochester, Minnesota, it was much lower cost and much healthier people and better outcomes. So this is really where that whole idea of ACOs, or accountable care organizations, came from. And the way that it manifests itself is they basically give a health system money, a fixed fee per patient, and ask them to manage the care within that, and then they actually get to share in the profits. So if they're able to provide better care at lower cost and make more profit, they're entitled to do that. Bundles are a little bit different. So bundles is, now we'll just take the example of what's going on with joint replacements. What's going on is that it used to be that they would pay the hospital and the doctor for the joint replacement surgery, and then they would refer to a post-acute care choice, as I said, mostly skilled nursing or home health, and then those organizations would separately submit to Medicare for their costs. Well, now what they're doing is they're giving the full cost to the hospital, and they're saying you're responsible also in this amount of money for the post-acute care, and they have to make a choice of what's the best post-acute care option for that recipient that prevents them from readmitting and gives them a successful recovery and also makes it profitable for the hospital. So that's what's going on there. So jumping to the third bullet, essentially, again, as I said, it means that the hospitals are paying out of their own pockets. They're paying out of their own profits for this post-acute care, and readmissions come out of their pocket as well. And kind of the most important bullet here is that to win in this era, it means that you have to have affordable offerings that don't result in a readmission. And as I showed on the previous slide from Dr. Josh Luke, this is what's opening the door for non-medical home care to play a key role in post-acute care. So this is the aforementioned graphic anyway from the Wall Street Journal article on Friday. And so this spells it out pretty well. So what they're basically saying is that the average bundled payment for a joint replacement is going to pay $27,870. And this is what in general, the cost of care would be for that procedure, and it's post-acute care. So if somebody goes to an LTAC or a long-term acute care hospital, it's going to cost $74,000, so pretty much 3 times as much as they're paid. And then as you move down the list, so inpatient rehab, here in Boston we have like Spalding Rehab, that kind of scenario is going to cost more like $41,000, skilled nursing about $36,000. So then really home health care is the first place where they're profitable, because with a home health care discharge it costs more like $20,000, and if somebody goes to the home it's $17,000. So this is what they're up against, but what we have to keep in mind is that certain people are going to need, let's say, skilled nursing. So if they send one patient to skilled nursing, they're going to have to make up for that to be profitable. So let's do the rough math. At $28,000 there and $36,000 here, they're actually going to lose $6,000 on this scenario, whereas in this scenario they're going to let's say make $8,000. So basically the whole trend is going to be to try to push patients to lower and lower places on this scale. And as I kind of alluded to earlier, instead of sending somebody to a skilled nursing facility where they can have people around them all the time, they'd much rather send them to their home, supplemented by home care, non-medical home care that is, so people can help them with their activities of daily living. And if that could be paid out of the that client's pocket, that's all the better for Medicaid, for CMS in this case, and for payers. So that's kind of where things are going. So that's kind of all the background of what we covered in the last webinar and why we have this situation. So now we'll kind of jump into the meat of this webinar, which are 5 attractive post-acute care offerings. And so I kind of repeated the picture there, but I put the little quote on the left. I said, if this were my mom and I had to pay for the care myself, what would I choose? And so this is really thinking about I kind of made it a little more personal by saying it's my mom, but really the hospital, since they're paying out of their own pocket, they're going to start thinking this way of what's the best care I could do here, knowing that I'm paying out of my own pocket. And so that's going to drive us into some offerings that are attractive and make sense. So the first offering I'm going to talk about is actually a safe transition home kind of a service that, in this case, I've taken an example from a home care agency. Even though it says home health care, this is actually a non-medical home care agency, and they're offering this service to clients in Florida. And so I've kind of bulletized it here in the bigger bullets, but it's pretty consistent with what it talks about in this that I've copied off their website. What they're doing is they're meeting the client at the hospital. They're spending some time with the discharge planners to gather information and everything that they need. And then they're providing safe transportation, picking up prescriptions and groceries. Maybe they did the groceries ahead of time. They're doing a home safety check. They're also getting rid of, I give the example of spoiled milk here, getting the person settled and updating the family. So, the scenario here is that, okay, we'll take my mom. So my mom lives in Florida. She's healthy and ambulatory at 77 years old. But if she did fall and injure, let's say, a knee or a hip or something like that, the scenario would be I'd probably fly down there and see her in the hospital and that kind of thing. But then I'd have to, really make sure she's, taken care of. But I would have to get back to my home and my job and my children and things like that. So if I were in the hospital and somebody handed me a brochure that said, hey, we have a safe transition home service that'll drive your mom home and make sure that everything's okay in the house and give you an update, and let's say it costs $199 or something like that, I would pay that in a heartbeat. So this is the kind of offering that people are starting to, to offer to kind of cover some of these situations. And as again, we'll talk about a non-medical home care agency gets their foot in the door to be working with hospitals and that kind of thing. And I didn't mention this last bullet, but it's very, very important. Anytime you have one of these programs, it gives you the opportunity to suggest follow-on services. So think about that. I mean, somebody's just been discharged. Again, they might have had a knee or a hip replacement surgery, and they're going to their home, and you've just been paid $199 for this. There's a very likely chance that unless that person has, maybe a spouse who could take care of them, or they live, with loved ones and have, family caregivers and things like that, that there's a very good chance that they're going to need help with other activities of daily living. So in addition to making this a profitable service, this could also, with a very high probability, turn into a referral for your agency to provide ongoing care for this person. So this is kind of the way you need to think about this. So I'm going to take a little tangent here for a second. I originally had this at the end of the presentation, but I think it's important to cover it here because this is what's going to be on a lot of people's minds going through this. It's like, okay, well, of course I could offer that service. Maybe I have to figure out, can I provide the transportation or not, or there's some little logistics, but you're saying, yeah, even if I could offer that service, how would I sell the service? And so, here's my kind of checklist of steps that you need to do. And so first, I kind of wrote this from the perspective of non-medical home care. And what you have to do in step one is overcome that historical fear of working with the healthcare system. So we kind of know that non-medical home care has always been shunned by the healthcare system because you're non-medical. So they're very comfortable with skilled nursing because that's medical, and they're very comfortable with home health because that's medical. And historically, they haven't been very comfortable or interested in talking to you. So you kind of have to overcome that fear as a step one. Now, I will kind of share the home health corollary, where now that the hospital's paying for more and more of the services out of their pocket, I guess in the case of home health, you might have to overcome your historical comfort zone where they're going to refer to you for a Medicare paid episode, because that's going to be declining as we go forward. So if you're in home health, you really have to start thinking differently and say, well, maybe for this person who's, in their 60s and they're very healthy and they have, and it's maybe a husband and he has a healthy wife who can take care of him and things like that, they are going to be less inclined to want to pay for that home health episode if they can do it in a more affordable way. So, so I guess, really if I were to rewrite the words for step one, it's, kind of think about what I've said earlier in the webinar about how the payment models are changing and how the hospital's thinking is kind of step one. And then step two, very basic, I'm saying make a brochure. Again, on the previous slide, I showed how, at least on the website of that agency in Florida, they at least have a web page about it and that kind of thing. I would say they probably have a brochure that goes with it. I took that example off the web. I don't know those people directly and that sort of thing. And then, kind of the question comes up, well, who do I talk to in the hospital, and how do I get into the hospital? And so, one piece of advice, or when I talk to people, I say, well, do you have clients, they work with your home care agency, who are ever in the hospital? And they say, of course. And I say, well, do you visit with those clients? And a lot of them say, well, sometimes we do, sometimes we don't. But this really is a great opportunity. So if you, first of all, it's great customer service. If you have one of your clients and they're in the hospital and you go visit them and spend some time with them, that's going to make a positive impression on that client. And if they did have any family who came in to see them, they're going to be happy to see you there. But that also gets you in the door with a reason for being there. And while you're there, then you could really figure out who you could talk to about these post-acute services. So, and again, you have the right to be there and say, hey, when are they going to get home, because we have to turn back on our home care and things like that. But then you could get access to that dispatch planner and ask for some advice. So I guess there's I tried to find the quote. I didn't find it right away, but there's a quote that goes something along the lines of, if you ask for a sale, you'll get advice, and if you ask for advice, you might get a sale. So I might not have that quote perfectly, but kind of the idea here is that if you go and you ask for advice and you say, hey, I have home care agency, we're providing skilled and non-skilled, or we're only providing non-medical home care, and we know that the payment models are changing and that it might be attractive to you to have other types of services, what do you think would be good? Could I get your advice? Asking for advice could be a really strong thing, and and you're not always going to be successful, but if you do get some time with the discharge planner and that kind of thing, then you could explain what you're thinking. Say, well, we're thinking of a private pay service where we're going to help the person get home safely, and you could walk through the brochure. And if they say, hey, I'm really interested in that, I can think of at least once a week or twice a week a scenario where a family would really benefit from that, and maybe they'll let you leave some brochures. And so I guess as we look at other offerings, it might be different. In this case, you're not really trying to sell to the hospital, but you're really trying to help them out. You're trying to say, hey, we have a service that might be valuable to some of your clients. You can send them our way, and we could help them, and that might actually take some work off the discharge planner's plate, as well as be providing a service that helps their client and gets you a foot in the door. So hopefully a win-win for, or maybe a win-win-win for the discharge planner, the client, and for your agency. So that's kind of scenario number one. All right, jumping on to number two, the classic way of dealing with post-acute transition is that there are evidence-based programs. So evidence-based means that they created a methodology and they documented it, and they went through some clinical studies, and then they had it published and reviewed by peers in some kind of a medical journal. And there are programs like this. There's more than the ones I've listed here, but probably the most well-known and most popular is what people sometimes call the Eric Coleman model. They actually call it the care transition intervention, and that's out of the University of Denver, and Dr. Eric Coleman's the guy behind that. There's also one out of University of Pennsylvania called the transitional care model, where the main doctor who authored that is Dr. Mary Naylor. And then there's a really nice paper referred to a number of times. There's an organization called NTOC, stands for the National Transitions of Care Coalition, and I think they're ntoc.org is their website, and they have a lot of free resources, and they have a nice paper that they call the 7 essential elements of post-acute care, or care transitions rather, and so all of these kind of outline a program. And I will say that if you want to do some of these things, you could, for example, look at how NTOC recommends, and you could do it on your own. But if you want to use the Eric Coleman or the Mary Naylor models, those are things that you can't just say, hey, we're doing the Eric Coleman program. You actually have to sign up and do their training and so on. So that's kind of how that goes. And some of the essential elements, I actually took what Eric Coleman calls the 4 pillars of successful care transitions, are managing medications. So these are really the reasons why people readmit to the hospital. They didn't manage their medications. They didn't close the loop with primary care. Sometimes primary care is not going to know that their patient was in the hospital or why they were there, and they might actually call in and to their primary care physician and ask for a question, and that primary care physician might say, well, take this medication that I gave you, and that medication might have been changed in the hospital. So that's another reason, really not having the hospital team and the specialist and the surgery team kind of in sync with what's going on in primary care. The third one is, teaching the patient to advocate for themselves, and in the Eric Coleman model, they use a personal health record paper document. They actually, have the care transition coach, in this case, write down on paper with the person information about their meds, information about their red flags, which I'll talk about in a second, and really why they were in the hospital and all those types of things. And then they teach them that, hey, when you go see any doctor, you need to take this paper with you and walk it through with them so they know what's going on and they know that you were in the hospital and those types of things. And then the last one is managing red flags. So this is, very condition specific. So let's say the person was admitted for congestive heart failure. The red flags would certainly be, gaining weight, or it could be, if you're feeling more congested and getting a loose cough, or you're feeling swelling at your ankles. Those are the types of things that for that particular disease they would tell you are red flags, and those are the things that need to be managed. So in general, what a care transition episode looks like is a lot like a home health episode. This is a typical scenario where you get a referral from the hospital, you accept the referral, and then you schedule this episode where you have actually your care transition coach, depicted here as a nurse, which it could be. Sometimes it could be a social worker, meeting with the person before they're discharged, syncing with the discharge planning team. Then they have to get transported home. Maybe you're providing that, maybe not. And then there's a visit into the home within the first 24 to 48 hours after the surgery that really make sure that they've picked up all their meds, they know how to take them, that the home is safe, some of those things that we talked about in a private pay service a minute ago. And then we're going to make sure that they do see primary care. And then in general, if that person seems to be in pretty good stead, then just follow-up phone calls is all they need, and then there's a discharge. Then there's a piece, we'll talk a little bit more about this, where in some cases there is some extra technology that's checking in on the people in between, and we offer one of those technologies in our company that I'll talk about. But then, kind of a more traditional would be telehealth. So like sometimes if somebody's discharged with congestive heart failure, they send them home with a scale, and they ask them to stand on the scale every day. And if they, have suddenly gained a bunch of weight, this would tell the hospital team that, or the home health team in this case, that something is awry and that they're not diuresing the fluids in their body and could be in trouble. So that's what's going on there. But this is in general what one of these interventions look like. It could be different for Coleman or Naylor or different models, but in general this is the shape of what they look like. And here's a specific example. This is one of the customers we work with. It's not in home health or home care, so to speak. They're actually an area agency on aging in Phoenix, and they're providing this type of service as we just walked through. So as you see, they kind of talk about those 4 pillars. They are actually partners with, and which essentially is the terminology for people who have worked with the Eric Coleman program and gotten the training. So they're an Eric Coleman partner, and they talk about essentially the 4 pillars here and what they're going to do. And then they point out specifically here that you can only be part of this program if you're being discharged from one of the hospitals that participates in the program. But that's what that offering is like. And we'll jump on to a third one. Okay, so the third one is really, as we talked about, is having private home care services. And so I heard there's a fairly well-known, kind of prominent guy who runs also in Phoenix, coincidentally, a home care agency. His name is Bob Roth, and he actually, I heard him in a webinar a few weeks ago where he explained that his average client that's getting their care is getting around 28 hours of care per week, but if you look across the people who were recently discharged, they're over 40 hours a week. And what he pointed out is that home health is great and necessary and wonderful, but that nurse is only there for maybe a 45-minute stop-in, and they're not really helping with activities of daily living. They're really just kind of making sure, again, we'll stick with the joint replacement scenario. They're checking that the blood thinner is working right, if the person's on Coumadin, that they're taking their meds, they're checking their vitals, they're looking at the wound. So they're really doing kind of the medical services, but they're not helping take care of the person. And again, I gave a very basic example here. If you had somebody in skilled nursing for 20 days at $600 a day, you're at $12K. If you look at the numbers that you saw from the Wall Street Journal article, they were actually saying that the skilled nursing would be more like $18,000. And so again, the hospital might be thinking, hey, I don't want to spend $12,000 to $18,000 if I can send this person home. And if I could have a home care aide come in, let's say for 2 hours a day, and and we're paying that person something like $25 an hour. So, there it's just much, much more affordable. So here, I guess I gave the example, 2 hours per day for a month is around $1,500. And so that's, really becoming attractive even for the hospital to pay for. So I guess, to a degree, when we think back to offering number one, I talked about a minute ago, we said, hey, this is a service that you're not selling to the hospital, you're just making it available to clients. But once you build a relationship with the hospital, then you could kind of say, well, we could actually, as compared to skilled nursing, we can provide, help with activities of daily living and feeding and things like that for someone, and it's more like $1,500 for a month, whereas, skilled nursing would be, I guess what's that, 30 days at $600 a day is, $18,000. So, so this could be a very, very attractive offering. So here I found, a very wonderfully done brochure that you could download from this organization called Preferred Care at Home. And this is the cover, and so they've really, from a marketing perspective, they've really done a very nice job of making this brochure available to people. And here I just, you can't read it in detail here, but you can just kind of see the measures they went to and the kind of the quality of the brochure they've put together for people to kind of talk about, how transitions of care work and what types of services they offer, and that type of thing. So it might be, it's actually even a little blurry on my screen, so it's probably even worse on yours, but this gives you some information about them. So, you might find their website if you want to pattern a program after what they've done. But, you can kind of tell that some agencies are jumping on this opportunity and they're really taking it seriously. And, this could be an opportunity for your agency as well. So that's number three. Number four is an offering, and here I kind of start with the disclaimer. So this is a product that my company offers. We call it Foresight Care, but we really do think it's something that is going to be very prevalent in being able to care for people very affordably. So what we do is we actually do remote patient monitoring, but unlike telehealth, where if we think about some of the complications of telehealth, of having to get an electronic scale in the person's house and all that connectivity and internet and things like that, we actually do it in a much more affordable way, and we just use the telephone to check in with, with high-risk people. And so what we would do is, so let's say that person just discharged with a hip replacement, but they also have a history of, let's say, congestive heart failure and asthma and urinary tract infections. We would put in that set of conditions, and then we have an algorithm, it's a fancy computer word for, a little computer program that goes and it kind of says, well, if we could take the best nurse we know and they could talk to that patient for about a minute, what would they ask? And based on that case mix of those four conditions, it would come up with simple to answer questions for them, like, again, with congestive heart failure, it would ask, are you feeling more congested or less congested than the last time we called? And if they said, I'm feeling more congested, they might, ask a follow-on question like, are you having a dry cough or a loose cough, and those types of things. And then for, again, for the possibility of urinary tract infection, we're just asking, are you, feeling any pain or unusual discharge when urinating? And for the hip replacement, we're just asking, things like if they have pain they can't control with medication, or if they have, You know, if they have any kind of bleeding or oozing or swelling at their wound site, and they're just answering with their touch-tone phone. You know, they give answers like, you know, press 1 if you're feeling about the same, you know, press 2 if you're feeling more congested than last time, and press 3 if you're feeling less congested. And based on that, it's almost like telephony for the patient. You know, we call and they answer this short list of questions, and this is a way that your agency could reach out to a large population of people in your census, and then it can alert your nurse as to, you know, who they should follow up with a live phone call. And yeah, the way it works, you just enroll them, as I say, put in their name, their phone number, and the conditions they face, and then you kind of make a decision based on their acuity. You know, are they in fairly good shape, in which case maybe the phone call happen every 5 days, or are they, you know, more sick where the phone call happen every day? We certainly don't want to annoy them, that kind of thing. And then it just automatically calls and monitors, and it lets the nurse know when something's up, so you could provide early intervention. So it could be that on any given day, you're calling out to, you know, let's say 80 people, and then you get notifications for, I don't know, 9 or 10 of those people, and say, hey, you know, you should follow up with this person, and it'll tell you exactly why. So that's kind of a fourth offering. And, you know, if you look at it from a home health perspective and how home health really needs to sort of transform into this model of providing, you know, better outcomes with fewer visits, this could really help. So in a typical intervention today, there might be like, let's say 14 visits in a home health episode, and in general, those cost around $100 per visit, you know, for a total of $1,400 in this scenario. With this new, you know, Foresight Care product, what could happen is that you add these automated phone calls in, and so let's say over a 60-day episode you add 20 automated phone calls, so 1 every 3 days, then you could, you know, in a lot of cases cut out nurse visits. So, you know, maybe in that case you're adding the automated phone calls, that costs you $30 for the episode of care, and then you've maybe cut out 4 nurse visits. So if you cut out 4 nurse visits, you've saved $400, and you have higher outcomes, and, you know, that'll lead to the types of things that you need in the future. You know, lower readmissions, higher star ratings, more referrals, and this kind of thing. So this is, you know, what we're going for there. And then if we look at it in the non-medical home care perspective, you know, this is again more for ongoing chronic people who, you know, high risk but low acuity, and they feel well on most days. And really the value proposition for home care is, you know, if you work with this service and people come into you and they say, well, you know, I'm trying to find home care for my mom, you know, you seem very similar to, you know, the 3 other agencies that I visited, what makes you different? Then you could say, well, you know, we actually have a technology that, you know, checks with your mom and gives us an early warning sign if there's, you know, a risk of a hospitalization. And, you know, so that's a really strong differentiator, you know, for your non-medical home care agency that, you know, might be very valuable. And, you know, it's very affordable because we don't have all of the, you know, the devices and the connectivity that you would need to, you know, deploy like a full telehealth unit. So that's what's going on there. So, okay, so, and then finally we're on to our, you know, offering number 5, and, you know, you might say, well, this isn't really an offering number 5, so I'll take that criticism, if you will. But what I'm really kind of getting at here is that you might have a hybrid kind of offering. It looks like, I copied the wrong slide in here, so I apologize for that. But, you know, what I intended to talk about on this slide was that, you know, you might combine any of the above things, and, you know, really kind of the way, again, thinking like an entrepreneur, what you have to do here is think about, you know, what do you have in your agency today, and based on what you have, you know, what could you offer? So if you're only non-medical home care, that might not be a bad thing, because hospitals and the discharge teams, they have nurses on staff, so maybe they'll work with you. But if you're, you know, kind of more the organization of the future that has, let's say, skilled nursing and therapy and care transition coaches and non-medical home care and a call center and automation, which is kind of what I get to in this picture, that, you know, you could really start thinking about, you know, a great offering. So, you know, so you could really provide a combination of services at different levels in this pyramid, and kind of have everything, if you will, practice at the top of its license, and really come up with a great outcome. So so maybe if you're home health today, you only have skilled visits with nurses and therapists, whereas if you're only home care today, you only have the non-medical. But if you kind of think about it, and this is what the next webinar will talk about, if you really have this combination of things, then you could treat every patient individually and say, hey, this is the best level of care for this person, and you could start, for example, taking a fixed fee for post-acute care for people who are sent to you, and really start saying, well, for this person we can put together kind of a customized set of things from this pyramid that costs less, and for another person we have something that's going to cost more, but we're pooling resources and sharing and not overlapping, because we have all the skills in our service. So without kind of going on, because that's the next webinar, I did want to talk about offering number 5 being this hybrid and combining the different services at the different price points and looking at each patient, coming up with the lowest cost and most effective service that you could offer, and that's how you're going to win in this value-based purchasing era. So with that, I will kind of encourage you that if you do have any questions, this will be a great time to type them into the question panel. And other than that, I'm just going to recap that we've kind of talked about how the payment models are changing, and we've talked about a number of low-cost solutions that you can offer with your care providers, whether they be skilled, non-skilled, or a combination. We've also talked about some technology solutions, whether it be telehealth, which is a little more expensive and cumbersome, or something that's more affordable like Foresight Care that I talked about, which is just calling out and checking in and giving you warning signs if something's up there. And again, this value-based purchasing is growing. So this year it should be 30% of all patients are value-based. There was a statement from CMS that by 2018 they expect more than 50%, and we see that as the trend for the future. And finally, again, just kind of ending by saying that the winning organizations will have these new offerings that optimize outcomes at the lowest cost. So let me jump in here and see if there are any questions. And let's see. Okay, so far I am not seeing any questions. And so if that is the case, then I will, I'll just have to think that we covered it reasonably well. I will say that next webinar that I referred to is going to be 3 weeks from today, which is the 27th at the same time. And so again, we're going to kind of come full circle and talk more about the model that we think will be the home care and post-acute care model of the future. And so hopefully if you enjoyed this webinar, you'll sign up for that. And other than that, not seeing any additional questions, I will thank you for your attendance for today. And also want to thank our friends at Healthcare Synergy for putting on this webinar series. And with that, we're going to call it the end of the webinar. Thanks again. Bye-bye.